If you would like to see it again, you can see it on our Piano website. So, welcome everyone. We are glad to have over 500 people from around the world registered for this webinar today on the global consensus for the management of inflammatory bowel disease in pregnancy. My name is Uma Mahadevan. I'm a professor of medicine at the University of California, San Francisco, and I was chair of this project. And I'd also like to have Professor Millie Long introduce herself.
Hi, everyone. Millie Long, also professor of medicine at the University of North Carolina at Chapel Hill, and I help to co-chair this consensus process with Uma.
Right, so let's start. I want to start by saying that this is recorded and will be posted on the pianostudy.org website, so you can go and watch it again. And also, the slides that we're using today will be released on the website, and you're free to use those for when you give your own talks on this topic. We really want to disseminate this information globally. The slide deck will be in English and Spanish. So IBD is often diagnosed during the reproductive years, making it essential to understand effects on fertility, pregnancy, and childbirth outcomes. Pregnancy represents a period of intense metabolic, hormonal, microbiome, and immunologic change, all things that can also impact inflammatory bowel disease. For women with immune-mediated diseases like IBD, this can increase the risk of pregnancy complications, in part due to the unique role of the placenta. We're starting to appreciate the role of placenta in immune-mediated disease and pregnancy more and more. Humans are the only creatures where the placenta embeds into the mother's uterus and the blood commingles. So you have this maternal blood here in pink, and here the round circle here is the fetal endothelial cell with fetal blood in the middle. And you have your syncytial trophoblasts, which help transfer maternal blood to the fetal system. The placenta is a highly immune organ and does seem to play a role in some of the complications we see in this patient population. There's limited human data on the safety of new therapies during pregnancy, and for IBD patients, stopping medications increases disease activity, leading to higher risk of maternal and fetal complications. For many years, and for many diseases, the default has always been to stop medications in the pregnant woman because of fear of harm to the fetus. What we'd like to show you today, and to show what the consensus has come to, is that stopping medication can lead to harm by causing maternal flare, which then leads to increased adverse outcomes in the infant. So many countries will look at the data and come up with their own guideline, which for this vulnerable population that has 9 months to go through this process of pregnancy and have a healthy baby, that can often lead to complications. We felt there was a need for universal guidelines with consistent interpretation of data with sensitivity to regional differences. So we gathered healthcare professionals and patient advocates from around the globe and followed GRADE and RAND methodologies. The paper is embargoed until August 22nd, 2025, but it does exist. This is what it will look like, and it's going to be published simultaneously in Clinical Gastroenterology and Hepatology, Gut, the American Journal of Gastroenterology, Inflammatory Bowel Diseases, Journal of Crohn's Colitis, and Alimentary Pharmacology and Therapeutics. So truly a global effort. Our global consensus physicians come from all 6 inhabited continents and have expertise in inflammatory bowel disease and pregnancy in IBD. Millie and I were co-chairs. Millie also led the GRADE process along with Ed Barnes. And I just wanted to show you the names of all the amazing physicians who participated. We selected a lead for each continent, who is the first name you see here, under each continent, and they selected the people from their region to participate in the consensus. We also had multidisciplinary consultants in lactation PharmD, placentology, teratology, maternal fetal medicine, and colorectal surgery, as well as global patient ambassadors who helped inform the questions we were asking and also are helping to disseminate this information throughout the world. I'm going to turn this over now to Millie to talk about the grade process.
Absolutely. And we did just get a question in the Q&A about when the paper will be available, and we believe that'll be available August 22nd. And it'll be published, as Uma mentioned, in multiple different journals, but also will be available on the Piano Study website. And so as we move through the methodology and more aspects of the global consensus, please feel free to type questions into the Q&A, and Uma and I will try to address those throughout the presentation and also at a Q&A at the end. We tried to use the highest level of methodology to really be able to assess the data for this global consensus. So when possible, we used GRADE. This is a universal grading system for evidence that includes categories of high, moderate, low, and very low. And this is based on a systematic process of evaluating the evidence. And when those data are available, we can then make a recommendation based on that grade. Strong recommendations are really when the benefits clearly outweigh the risks, outweigh the risks, and conditional really has some degree of uncertainty. I will say that really only randomized controlled trial level data, large meta-analyses really provide that high level of evidence. And in pregnancy, we clearly don't have that. So we do have lower levels of evidence. And when possible, we really made this great assessment and allowed us to do recommendations. Anything with a strong recommendation means that most patients would prefer the suggested action, and that clinicians should generally offer it. So next slide. We also had data for this consensus that really was only animal data, for example, or we really just didn't have any physiologic evidence in humans. And therefore, we really still wanted to provide expert consensus surrounding recommendations in these scenarios. So we did also perform a RAND consensus panel, which really combined evidence and expert opinion with two separate levels of voting and consensus discussion in between with review of the evidence. We calculated something called the RAND Disagreement Index, and this allowed us to see when our whole international panel was in consensus that an intervention was appropriate by having general agreement. And so we'll present those results to you as well, and note when the recommendations are based on this expert consensus. So really overall, we divided this consensus document into 10 different sections. And each of these sections had a lead and really had a robust evidence kind of summary within each field. And we'll actually review each of these during the course of this webinar. Maternal factors impacting pregnancy, fertility, preconception counseling and optimization, management of disease activity during pregnancy itself, management of pregnancy, and importantly, IBD medication use during pregnancy. We'll also have a section on lactation, pregnancy adverse events, fetal and neonatal adverse events, and then finally, vaccines. So we'll start with the maternal factors impacting pregnancy. So the first grade statement was that we suggest counseling that children with first-degree relatives with IBD, as compared to those without, have an increased risk of development of inflammatory bowel disease. This was a low level of evidence with a conditional recommendation, but important as we're discussing risk factors and data with our patients. Next slide. A consensus statement is that children born to parents with Crohn's disease, one parent with Crohn's disease, may have a higher risk of developing IBD than children born to parents with ulcerative colitis. We see that predominance somewhat increased for Crohn's versus UC. Next slide. And we really also want to emphasize that we feel there's a role for maternal inflammation in pregnancy. And as Uma so clearly presented to us earlier, that the placental function is really key to the growth of the fetus. And that abnormal placentation is really linked to major obstetrical complications. And actually, not only in inflammatory bowel disease, but other autoimmune states, it may be that maternal inflammation can affect this placental function and raises the risk of miscarriage, preterm birth, and small for gestational age. Therefore, this active inflammatory process in inflammatory bowel disease can have this negative effect on development or function of the placenta. So when we think for kind of counseling purposes about what increases the risk of inflammatory bowel disease in offspring, there are data surrounding a couple of different factors. One being antibiotics, one being diet, and another being the maternal microbiome. And I think what's important about these data are that they're potentially modifiable and some counseling that we can provide for our patients. So these are data surrounding antibiotic use on IBD risk in the offspring. And a number of different studies, including a meta-analysis of observational studies, as well as two population-based studies, did show that maternal exposure to antibiotics does seem to increase the odds of development of inflammatory bowel disease in the offspring. You can see it in an odds ratio, an adjusted hazard ratio, kind of in the neighborhood of 1.5 to 2. And so this is something that may, in fact, be a risk factor for the fetus, and therefore, if it's modifiable, if a mom does not actually need an antibiotic, then it may be something that could be explained to the mom, so that if she had a viral infection that does not necessarily need antibiotics, she may choose not to do so during the course of pregnancy. Next slide. When we think about diet, what the literature review demonstrated is that a Western diet in IBD mothers may actually affect the risk of inflammatory bowel disease in offspring. On the left, you'll note the Mommy IBD study, which was just published last year, which looked at 3 sites in Hong Kong and mainland China. And the IBD mothers had a higher food additive intake than the non-IBD mothers. And this food additive intake was also associated with changes in the microbiome. But interestingly, the fecal calprotectin was significantly higher in the gut of infants born to mothers with higher kind of food additive intake in IBD and non-IBD groups, showing that this may have an effect across the spectrum. The MELODY trial also is currently ongoing, and we'll actually look at an IBD anti-inflammatory diet, and so we'll actually be able to see if modifying this actually improves outcomes. Next slide. Finally, the microbiome. We do see the maternal microbiome as being altered. Abnormal gut microbiota composition can persist in mothers with IBD during pregnancy. And the Mommy IBD study really showed that that the altered gut bacteria, virome, and fungi in the IBD mothers really was up to 18 months postpartum. And this, in effect, could be associated with various other factors, including cesarean sections and maternal antibiotic exposure, which can lead to decreased vertical transmission of bacterial communities to infants. So really, we think the microbiome may play a role as well. Next slide.
Okay, so we are going to shift gears and look at fertility. Millie, when I try to look at the Q&A, I move the slides, so I'm going to let you
Okay,
do
I've
the
got the Q&A.
Q&A. So fertility, this is something that even in the pediatric populations, there's concern. If you have IBD, can you get pregnant? Is it harder to get pregnant? And we do know that there are key factors contributing to reduced fertility in women with IBD. Things that can reduce fertility: having active disease at the time of attempting conception, having a history of surgery in the pelvis, particularly ileal pouch anal anastomosis. Women with IBD may have lower ovarian reserve, and they may also delay childbearing. So let's look at the grade statements. We suggest counseling that women with IBD may have decreased fertility compared to women without IBD. We also, in women with ulcerative colitis, we suggest counseling that prior ileal pouch anal anastomosis is associated with decreased fertility when compared to women with UC who have not had an IPAA. One interesting question is there a difference if you do laparoscopic versus open surgery? And we thought that perhaps a laparoscopic approach led to better preserve fertility. However, a recent study from Mette Julsgaard's group in Denmark showed that it did not seem to make a difference, at least in that study. So any type of IPAA can decrease fertility in this population. In women with IBD, we recommend counseling that active disease increases the risk of infertility as compared to inactive disease. So this is really important. We want our patients to be in remission, ideally, when they consider conception for the best outcomes. if they need assisted reproductive technology, compared to women without IBD, we feel the effectiveness is comparable. And we suggest counseling that women with IBD who've undergone pelvic surgery have similar effectiveness of IVF when compared to women without IBD as measured by live birth. So if they're unable to conceive, reproductive technology can be helpful. Now, to go on to the consensus statements, women with IBD may have reduced fertility compared to women without IBD due to reduced ovarian reserve. This is an important conversation to have with your patients. A reduction in ovarian reserve measured by anti-Müllerian hormone is something to keep in mind. And we tell our patients you don't want to delay fertility if you can help it based on your life circumstance. And measuring anti-Müllerian hormone to assess ovarian reserve is indicated in this patient population. Women with IBD may undergo oocyte retrieval without increased risk of flare. Now, this was truly a consensus statement because there's very little published data. This was our collective global experience. And this is a question that comes up every single day with women interested in egg freezing. Now, one question we could not vote on because there was truly inadequate data is that women with IBD may continue all IBD therapy except methotrexate during oocyte retrieval. So what we say for oocyte retrieval is if you can use the medication in pregnancy, you can use the medication during oocyte retrieval, but things like methotrexate should be avoided. And again, there is no consensus on this.
So Uma, before we move on to preconception counseling, we did have one question kind of pertaining to the data we showed and surrounding the antibiotic use in the microbiome. Would you consider recommending probiotics prior to and during pregnancy?
So that's a difficult question because I think the data for probiotics and IBD has been so poor so far. So I do not. In pregnancy itself, there is some data for probiotics, maybe reducing preeclampsia, maybe reducing other complications. But I think a lot of it is association data, just like in IBD. And so I do not. I think the key is a healthy diet, avoiding ultra-processed foods and food additives, and avoiding unnecessary antibiotics. What do you do, Millie?
I do the exact same. I think the key take-home message is emphasizing to our patients a healthy diet, avoiding food additives. We do have some data there. And then the idea of avoiding unnecessary antibiotics. When antibiotics are necessary, absolutely, we need to have the mom take them. But I think those are probably the key interventions. I haven't moved to recommending probiotics for the same reason you have not. So our next topic is management of preconception counseling and optimization. And here we have really a strong recommendation that women with inflammatory bowel disease undergo preconceptional counseling. And the data are very clear here and robust that this will improve outcomes for our pregnant patients. Next slide. We also have consensus statement that women with IBD desiring contraception should use long-acting reversible contraception over estrogen-containing contraceptives. And we'll show you a little bit of these data, but essentially the concern with estrogen-containing contraceptives are some concerns surrounding absorption, adherence, therefore impacting some of the efficacy. And then with estrogen containing oral contraceptives and the potential for active inflammation from IBD, the risk of venous thromboembolism, which is also increased with pregnancy. And so, overall, the idea behind this is we want to try to use a low risk, longer acting, effective contraception without estrogen. Women with inflammatory bowel disease should also be documented in remission and medically optimized prior to elective conception. And this leads back into the data that active inflammation is what increases the risk for some pregnancy complications. Next slide. So when we think about contraception options, barrier methods obviously protect against STIs, and from that standpoint, can be an effective add-on, to other contraception. Oral contraceptives, the literature show that there is an increased risk of VTE, albeit low, human error and absorption issues. And with progesterone only, it's more the human error and absorption. Whereas these longer acting reversible contraceptives are most effective, no estrogen, no increased risk of VTE. Next slide. When we think about preconception counseling, what the data show is that this can be incredibly helpful for cessation of substances such as smoking or other marijuana use, other drug use, stopping teratogenic medications, ensuring that active disease is in remission, doing a nutritional assessment and initiating prenatal vitamins, ensuring weight management, having appropriate vaccinations prior to pregnancy, that really the collaboration with preconception maternal fetal medicine when appropriate, ensuring the patient is understanding of a robust IBD treatment plan. If needed, referral to a fertility specialist earlier rather than later, and ongoing physical activity and the benefits there. So really this menu of preconception counseling, I would argue, does not need to be given by an MFM, but could be given by the gastroenterologist or other provider caring for this patient. Next slide.
So, Millie, the UNC group published out of Piano the failure of contraception in pregnancy. So we looked at patients in Piano who had unintended pregnancies, and are there any lessons there supporting use of LARC?
Exactly. So I would encourage you, if you've not seen it, it's a paper in IBD Journal that looked at those mothers in Piano who actually had an unintended pregnancy and were on contraception prior. And the vast majority were actually on oral contraceptives, these combined estrogen, progesterone, or progesterone only contraceptives. And I think it shows that human error can play a role and that it's not as robust in terms of really the idea of maintaining contraception. There are also some data, out of Scandinavia that looked at women with Crohn's disease, and that oral contraceptives may actually increase the risk of recurrence in those scenarios. And so there are a number of different reasons why oral contraceptives may not be the most ideal, particularly for a woman who is really trying to avoid pregnancy. And in those scenarios, I actually in my clinic am recommending the hormonally coated IUDs because of that robust kind of contraception control, the lack of risk of VTE, like we described, and really just the consistency of it.
Right. Okay, excellent. So let's talk about management of disease activity in pregnancy. So our grade statement here is that we suggest that urgent and emergent IBD surgery during pregnancy be completed when required and not based on trimester. You may have all heard the adage that the only time you can operate in the second is in the second trimester, and that really is not based on good evidence, particularly in IBD. So the level of evidence for the statement is very low, and the recommendation is conditional. But we want to treat the IBD patient with whatever surgery is appropriate. This is not elective surgery. This is urgent and emergent surgery. And it really can be done at expert centers with a good colorectal surgeon in any trimester. The consensus statements: endoscopy during pregnancy among women with IBD is low risk, but should only be performed if it may change management. Most of the time, what we're doing are flex cigs in patients with ulcerative colitis, and those are very low risk. If you need to do a full colonoscopy, obstetric anesthesia does need to be involved. If cross-sectional imaging is needed during pregnancy, intestinal ultrasound and magnetic resonance imaging without gadolinium are preferred to CT tomography, and that fecal calprotectin is useful for monitoring disease activity in pregnant women with IBD. So this is a useful chart to have when you have a pregnant patient in your office and you're wondering, are they in a flare or is this their pregnancy? Remember that serum inflammatory markers can change in pregnancy. CRP and sed rate can be elevated from pregnancy. Alkaline phosphatase is elevated in pregnancy and breastfeeding. Calprotectin, however, is effective for monitoring in pregnancy. And serum drug concentrations, though, may vary in pregnancy, but still can be helpful, particularly if you're looking for anti-drug antibody. Intestinal ultrasounds low risk and accurate in the first and second trimester that can become very technically challenging in the third trimester. If you need a CT scan, it is relatively safe. The cumulative radiation exposure of a single CT scan is below the level of concern. For an MRI, it is low risk, but you do want to avoid gadolinium, which is a potential teratogen, especially during the first trimester. Endoscopy, low risk, can be performed if indicated and will change management. And the ASGE just updated, I think last week, their endoscopy and pregnancy guidelines, so you can refer to that. And with surgery, as we said, should be performed if indicated, regardless of trimester, and indications include acute severe UC, perforation, abscess, refractory hemorrhage, and bowel obstruction.
So now we'll move on to the management of pregnancy. Next slide. Perfect. So for grade statements for this section, this is a really important new recommendation that we suggest pregnant women with inflammatory bowel disease take low-dose aspirin by 12 to 16 weeks gestation to prevent preterm preeclampsia. This is a conditional recommendation with a low level of evidence. But that said, this will really has direct data of improving outcomes and preventing preterm preeclampsia, for which our IBD patients are at increased risk. We do suggest that pregnant women with Crohn's disease and active perianal disease undergo cesarean delivery. This is to avoid complications of a complex vaginal tear that can exacerbate underlying perianal disease if it is active. We also suggest that pregnant women with IBD and prior ileal pouch anal anastomosis consider cesarean delivery. In fact, we'll show you some of the outcome data, but when someone does have a vaginal delivery with a complex tear, this can affect sphincter control and pouch function over time. So while a vaginal delivery is certainly an option for these women, they do need to be counseled about the potential complications of a tear that could have effects in terms of long-term outcomes. Next slide. Consensus statements, pregnancies for women with IBD should be considered as high risk for complications. And that consideration of high risk means that we need to impart special factors such as the preconception counseling, the monitoring, and the things we're discussing today. Women with current or past history of rectovaginal fistulas should deliver by cesarean delivery. I think all of us felt that a rectovaginal fistula is so difficult to heal and so difficult that should you have a tear or worsening of this, it could be really dramatic for a patient. And that's why the consensus group really felt that even past history should really have consideration for a cesarean delivery. Women with inflammatory bowel disease should be assessed early in pregnancy or preconception for nutritional status, weight gain, and micronutrient deficiency. This is a key consensus statement that our colleague from MFM on the panel felt was imperative and will actually help to improve outcomes for our patients. Next slide. When we look at preeclampsia, it is one of the leading causes of maternal and perinatal morbidity and mortality. And women with IBD may have an increased risk of preterm preeclampsia. Low-dose aspirin can prevent preeclampsia in at-risk patients. Next slide. These are data from the ASPRE study, which looked at low-dose aspirin in a group of at-risk patients. It was a randomized controlled trial of aspirin at a dose of 150 milligrams daily. And it was initiated from anywhere from 11 to 14 weeks gestation up to 36 weeks of gestation to these women at high risk. And in this study, this is a pretty dramatic odds ratio. The adjusted odds ratio was 0.38 for development of preterm preeclampsia. Thus, it was highly effective at preventing this complication. So women with a high risk of preeclampsia without IBD in this particular study really demonstrated exceeding benefit. And importantly, in a study out of UCSF, they looked at the risk of IBD flare in women taking low-dose aspirin and really showed no evidence of this. And so that is reassuring that a low-dose aspirin does not have adverse consequences, but may have dramatic benefits. It is important that this be started by week 12 to 16 of gestation. And typically in my patients, I'm actually starting this at week 11 as per the ASPRE trial. And consideration for stopping at week 36. And what this does is at that point, they're past the risk of preterm preeclampsia because they've gotten through the preterm time period. And this may help reduce risks associated with bleeding surrounding C-section delivery, et cetera. So if you remember that week 11 to week 37, that we really should be providing low-dose aspirin and that don't have necessarily a risk of flare, but a significant benefit. Next slide. So, why is this important? Women with IBD really seem to have this increased risk of preterm preeclampsia. This preeclampsia can typically affect anywhere from 2 to 5% of pregnant women, and really can be associated with maternal and perinatal morbidity and mortality. In a large Danish national birth cohort, severe preeclampsia was elevated in women with inflammatory bowel disease with a hazard ratio over 2 of 2.2. And another study from the National Inpatient Survey, Crohn's disease was associated with an increased odds of preeclampsia with an odds ratio of 1.5. Therefore, the data are fairly consistent that there is this increased risk, and we have a benign intervention that can help us to prevent it. Next slide. What does high risk pregnancy mean? I mentioned that this can mean different things. Remember that this consensus was really an international consensus in high risk and low risk, low resource even settings. And so certainly here in the US, that might mean maternal fetal medicine clinics. In other areas, it could be a specialist in IBD who has expertise in pregnancy. In others, it simply may be education for midwives concerning risks and what to look for amongst IBD patients. But we truly feel that no matter what the resources you wrap around the patient, they certainly should be considered more high risk and have access to those resources. Next slide. When we think about cesarean delivery for women with a prior IPAA, there are conflicting data, and I think a woman can rightfully and reasonably choose to pursue a vaginal delivery. When there was a systematic review of 8 studies where there was no difference in pouch function except for complicated vaginal delivery. However, it's very hard to predict who will have a complicated delivery versus not, and so we do need to advise and counsel our patients. One study did show reduced squeeze pressure, more sphincter defects, and worse quality of life in women with a vaginal delivery as compared to C-section. So therefore, presenting patients with some of the data to help to choose what may be right for them. Next slide. IBD medications during pregnancy is next, but we do have one question prior to pursuing into that section. So Uma, one of our participants asks, regarding aspirin, many gynecologists do not share this view, and whether this is a recommendation applied uniformly to all patients or if there's any stratification based on individual risk factors. How are you managing this in your practice, Uma? Are you recommending this amongst all IBD patients or certain IBD patients?
So in our practice, we have a very close relationship with our maternal fetal medicine team, and they all universally agree and start our patients on low dose aspirin. I have had patients, because we get patients from all over the Pacific Northwest, Northern California, who do have OBs who disagree. And with that, um, I think that what we do is we stratify the patient. So if they have other risk factors for preeclampsia, particularly prior preeclampsia, then they'll certainly need to get it. And the OB agrees. So, for the single risk factor of having inflammatory bowel disease, I've personally just gotten on the phone and talked to the OB and presented the data, and often they will agree. And the patient certainly wants to do it as well, particularly if there's no increased risk of flare. I think with the global consensus coming out with a MFM as part of the advisory panel, it's Chris Robinson. I think that will help provide credence to these guidelines, and it's something that we can show the OB and say, look, your MFM colleagues are also in agreement with this. And you can always prescribe the low dose aspirin yourself. It's not something that you have to wait for your OB to prescribe.
Mm-hmm. And there's one follow-up question as well. Is this increased risk of preeclampsia directly related to disease activity, or can it be seen independently?
I think it can be seen independently. It does look like disease activity can make it worse, but this goes back to the placenta. As part of Piano, we're collecting placentas in women with IBD, and we are seeing that even in remission, their placentas are not normal. They don't look exactly like the placenta of a patient without inflammatory bowel disease. So having an immune-mediated disease impacts the placenta, and that is a driver of a lot of these placental complications. And so I do think that any patient with IBD is at risk, and it is a very minimal intervention to make, a low risk intervention that can prevent a pretty big complication.
Yeah, I agree. And I think you're exactly right that it's so hard in many of the studies. Some were active, some were not. I think, as you mentioned, active disease plays a role, but it's not the sole factor. And so we certainly need to be able to provide a minimal intervention that may really improve outcomes for our patients. One other question
Absolutely.
on the management of pregnancy before Uma will jump into the big section of IVD medications during pregnancy is that there was a question surrounding kind of induction and whether or not we addressed whether an individual with IBD should have a induction prior to their due date. And that is not something that we addressed during this consensus, but certainly is something where we're continuing to accrue data, particularly in the piano study, where we're trying to better understand outcomes of individuals who come in for an elective early induction.
Yeah. And for that, we generally leave it up to their OB because there is
Mhm.
no IBD specific data. But I have to say, many of my patients are offered induction at 39 weeks. What about at UNC?
I agree. I think that's it's broadly for my patients, but I think even for patients without IBD, we're seeing that in the OB practice, and so I do think it'll be important to understand at least in the general OB practice for low risk patients. Obviously, there are no significant adverse outcomes associated with that.
Absolutely. So more to come on that. Great question. Okay, so what about medications during pregnancy? So the guidelines really have evolved on this, where before it was always stop everything or stop in the second trimester or count the weeks, stop early. So what you're seeing with the global consensus is we're saying for biologics, do not stop the medications, continue them through preconception, pregnancy, and lactation. While some IBD medications may have limited safety data, it's very clear that de-escalating therapy and stopping biologics before the third trimester led to more flares. And there are large population-based studies, including from France, as well as meta-analyses supporting this. And the reason why it's challenging to make these recommendations is that pregnant women are not included in IBD clinical trials. If they're in a trial and they get pregnant, they're booted off the medication and may not be followed. So when a drug comes to market, we have very limited, if any, safety data. Most of it comes from animal reprotox studies. There's unmeasured confounding in uncontrolled studies, and existing disease activity and prior history of severe disease certainly impacts a decision to continue or stop therapy, and those are also risk factors for complication. There's low event rates for adverse events, small cohort sizes. Remember that birth defects occur in about 5% of all births. So if you see a birth defect, it really needs to be the same birth defect over and over for it to really be associated with the drug. If you see 5 different birth defects over time in a particular drug, it could be unrelated. And that preterm birth predisposes to neonatal infection. We know women with IBD may have higher rates of preterm birth. So is that infection from the preterm birth or from exposure to drug? And all of these questions make it very difficult to understand the role of the medication. And we're going to go back to the placenta, which is very important. And as we discussed, humans are the only creature where the placenta embeds into the uterus and maternal and fetal blood commingle in the vessel. And what you see here is the baby, the placenta, the placental villi, and the pink, the maternal blood. But when you take a biologic, and here are the antibodies, the FcRn, the receptor on the syncytial trophoblast, develops at around week 13 or 14 of pregnancy. So the key period of organogenesis is weeks 3 to 8. And during that time, biologics or antibodies are too big to really passively cross the placenta. So there's no or minimal exposure to the fetus during that time period. But beginning around week 13 to 14, the FcRn develops, and then you get active transfer from maternal blood across the syncytial trophoblast through the fetal endothelial cells into fetal blood. And 80% of that transfer occurs in the third trimester. So when a baby is born, they will often have higher levels of drug than the mother. So if we're not as worried about birth defects, because there is an exposure during that key period of organogenesis, should we be worried about what is the effect of the baby being born with these therapeutic levels of drug? Now, small molecules, on the other hand, will passively transfer across the syncytial trophoblast of villus into the fetal blood from the beginning because they are small molecules. And so that transfer is passive and can occur from very early in pregnancy, which is why we treat biologics and small molecules differently with respect to our understanding of their safety in pregnancy. So our grade statements for women with IBD who are pregnant or attempting conception, we recommend continuing maintenance 5-ASA therapy. This recommendation is strong. We have no data suggesting there's an increase in birth defects with 5-ASAs. In women with IBD who are pregnant or attempting conception, we suggest continuing maintenance sulfasalazine. As a caveat, they should increase their amount of folic acid to 2 milligrams a day. We suggest the use of corticosteroid therapy when necessary with appropriate monitoring. Steroid therapy in pregnancy is associated with complications of pregnancy, which may be due to the active disease it's treating, but this should not be your maintenance therapy in pregnancy. You use it if you need it, but not as your maintenance. In the old days of biologics, they would stop the biologic and have the patient on steroids throughout pregnancy because they were afraid of the biologic. That actually leads to more complications. We do recommend discontinuing maintenance methotrexate therapy at least 1 month prior to attempting conception. This is a strong recommendation. And we suggest continuing maintenance thiopurine therapy as data does not demonstrate an increase in birth defects or infant infections. In women with IBD who are pregnant or attempting conception, we recommend continuing maintenance anti-tumor necrosis factor therapy throughout pregnancy. This is a strong recommendation based on no evidence of harm and clear evidence of harm when you stop the drug early. We do suggest continuing combination therapy with anti-TNF and thiopurine therapy throughout pregnancy in those patients who need it. In those patients who are on it, and we suggest continuing maintenance vedolizumab therapy during pregnancy and continuing maintenance ustekinumab therapy throughout pregnancy. These are the grade statements. The consensus statements are that women with IBD who are pregnant with active disease should start or optimize the same appropriate therapies as in non-pregnant patients, with the exception of thiopurines, methotrexate, JAK inhibitors, and S1P modulators in pregnancy. In women with IBD who continue thiopurines during pregnancy, precaution should be taken for intrahepatic cholestasis. This was a recent FDA warning. And if you are using thiopurines, you should measure liver enzymes and metabolite levels. And if there's evidence of shunting, consider splitting the dose. Women with IBD who are pregnant and have infections, fistula, or pouchitis that require antibiotics may take an appropriate course of a low-risk antibiotic. Women with IBD may initiate or continue calcineurin inhibitors such as cyclosporin and tacrolimus during pregnancy with careful monitoring if there are no viable alternate treatment options. Women with IBD who are pregnant or attempting conception should continue biosimilars to existing biologics. Our European and Asian colleagues really were surprised that we felt we needed to put this in the guidelines, but this question comes up all the time in the United States and Canada. So if they're on a biosimilar of an existing biologic, they can certainly continue that, and we treat it infliximab, adalimumab. Women with IBD who are pregnant or attempting conception should continue anti-IL-23 therapy throughout pregnancy, mirikizumab, risankizumab, guselkumab. Now, the small molecules. Women with IBD should discontinue ozanimod at least 3 months prior, etrasimod at least 1 to 2 weeks prior, tofacitinib at least 4 weeks prior, and upadacitinib at least 4 weeks prior, filgotinib at least 4 weeks prior to conception, unless there's no effective alternate therapy to maintain maternal health. So with the JAK inhibitors in particular, patients are often on these medications because they don't have an alternative. And in that setting, there should be shared decision-making with the patient about continuing this through pregnancy, looking at what other medical options they have and what other options for starting a family they have. Going back to consensus statement 13 with the thiopurines, there was a recent FDA announcement in April of 2024 warning about the rare risk of intrahepatic cholestasis of pregnancy. And both Jarup and Flanagan published on this, where the MMP to TGN ratio increases over pregnancy, and that increase may be associated with the intrahepatic cholestasis. So there's an incidence overall of this of 1% in the general population. So what you can do if you have a patient on a thiopurine, one, you should be monitoring liver enzymes, and I usually check metabolite levels at least once during pregnancy, and if there is evidence of shunting, will split dose of thiopurine, or more often maybe even change therapy. Allopurinol can be used as co-therapy. There's very limited safety data there. So just to summarize, aminosalicylates, folic acid supplementation, as we talked about with sulfasalazine, can be continued throughout. Thiopurines can be continued throughout. Monitoring liver enzymes and metabolite levels. Methotrexate is a known teratogen, should be stopped 1 to 3 months prior to conception. Steroids can be used if needed for appropriate reason and should not be used as maintenance therapy. You should employ steroid-sparing therapy as you would in the non-pregnant patient. TNFs, anti-integrins, anti-IL-12/23s, and IL-23s can be continued throughout preconception and pregnancy. Now, for JAK inhibitors, use only if no other viable option for maternal health. We talked about the newer IL-23s, or the newer biologics. This was just data in inflammatory bowel diseases looking at risankizumab placental transfer. Some of the newer biologics have different epitopes. You can see here the maternal levels on the day of birth in the patients 1, 2, and 3, and you can see the infant levels and cord levels, which are the same, are much lower. So the ratio of infant to cord is much lower than what we saw with infliximab, ustekinumab, adalimumab. This is available data on tofacitinib. This is from the Global Clinical Program looking at 85 maternal exposures. They did not see an increase in birth defects. Again, very low numbers. For upadacitinib, 128 maternal exposures. Again, no clear increase in birth defects or miscarriages, very low numbers. We need a lot more data here. And again, if there's no other option for the patient, we will use it, but it needs to be done under advisement with the patient aware of the available data. With that, I will transfer to Millie for medications during lactation. I think you're on mute. Yeah.
Before I jump into that, there's one question that I want to hit home. And there was a question about, do we adjust medication prior to delivery? And I'll just take that. No. Back even a decade ago, we used to try to, adjust their infliximab dosing, let's say, so they would get it early in the 3rd trimester, hold it. In fact, that just amounts to increased risk of flare for the mom. And in fact, at this point in my practice, I am not adjusting any of the biologics. They stay on. It actually makes it easier for the patient and really, in fact, improves outcomes by allowing them to stay on therapy and prevent flares of disease. Do you do the same in your practice, Uma?
I do exactly the same. I just tell them to continue throughout pregnancy. Now, if their dose falls on their due date or the day before, I will say, oh, why don't you wait till you deliver? But that's really doesn't matter. We've shown together in the Piano publications that the drug level at birth had no association with complications. So I continue it.
I continue it. And I think that's the key take-home message, continue. So let's move on to the next slide for lactation. In fact, the transfer of monoclonal antibodies, as Uma has described in the placenta, when we now shift to blood to the breast and the transfer into breast milk, what you see here in this picture in the upper part of the diagram is the monoclonal antibody transfer, and on the bottom part is the small molecule transfer from the maternal blood into the breast milk. On the next slide, you'll see that there's a big difference between monoclonal antibodies and small molecules in this fashion. So with monoclonal antibodies, when you look at the maternal serum and the studies of those used in inflammatory bowel disease, less than 1% of the concentration on the maternal serum actually makes it into milk. And then less than only about 50% of that is digested. So you're looking at less than 0.5% in the infant GI tract, which then when you look at radiolabeling and other factors, you see that only 0.01% of that is absorbed. So overall, the infant serum is essentially undetectable, less than 0.005% of the maternal serum. And so really what you're looking at here with monoclonal antibodies and breastfeeding is that we recommend just continuing the monoclonal antibodies. For most drugs, a weight-adjusted percentage of the maternal dose of less than 10% is considered relatively safe. And when you look at these monoclonal antibodies in these infants, it's exceedingly low. So therefore, in infants exposed in utero to infliximab, adalimumab, vedolizumab, ustekinumab, etc., maternal breastfeeding does not affect neonatal clearance of the drug. So really, this is something that is safe and recommended should the mom wish to pursue it. Next slide. Now, small molecules are different, and small molecules are readily absorbed. So we'll talk a little bit about the individual drugs. So the first statement, we recommend breastfeeding as it is not associated with an increased risk of disease exacerbation in women with inflammatory bowel disease. So therefore, we should be supportive of breastfeeding generally, should our IBD moms wish to pursue that. Next statement, we suggest counseling that infants born to mothers on anti-TNF therapy who breastfeed have no increased risk of infection in the first 12 months of life. And this becomes very important, and it shows that the clearance that I just demonstrated to you, that in fact it's microscopic levels, if even there, in the first early time period after delivery from prenatal exposure. And then obviously for those women who breastfeed, the infant is essentially getting no exposure there. So we actually recommend continuation and that it should not affect the maternal treatment if she's on a biologic. Next slide. Consensus statements, mothers with IBD currently on any of the mesalamines or sulfasalazine, thiopurines, corticosteroids, anti-TNF, anti-integrins, IL-12, 23, IL-23, and biosimilars to the biologics may breastfeed. So really overall pretty simple. Next slide. The difference falls with the small molecules. So we do recommend avoiding breastfeeding if the mother is on an S1P receptor modulator or a JAK inhibitor, because these are readily absorbed and therefore infants would have a level detectable, and we don't recommend that. Next slide. So just in summary, if you think this through, it's really safe to breastfeed on all of our mainstay of therapies on the left. The ones to avoid include the small molecules S1P receptor modulators, JAK inhibitors, and methotrexate. And really, I would argue potentially the methotrexate and the S1Ps, we can really substitute alternate drugs. It's certainly the JAK inhibitors, if needed for maternal disease activity, that in many instances we may not have another good option. And for those moms, we would recommend avoiding breastfeeding. Next slide. When we look at JAK inhibitors, tofacitinib has actually been studied and has been detected in breast milk of 2 lactating women. And the worst case scenario is that the relative infant dose is 3.4%. When you look at data for upadacitinib and filgotinib, there are really no human lactation data available, but the EMA and the FDA both recommend avoidance of breastfeeding. Therefore, due to no or limited human safety data and the unknown effects on the immune system, this is why we really truly recommend avoiding in the case of treatment with a JAK inhibitor. Next slide. So moving on to pregnancy adverse events, Uma.
I just want to add that Dana Durakova, who is one of our global consensus participants or consultants, did just publish very recently upadacitinib data, look very similar to tofacitinib data. Again, we would not recommend breastfeeding, so we'll update this slide for that. And then pregnancy adverse events. So the grade statements, we suggest counseling that women with IBD as compared to women without IBD have an increased risk of adverse pregnancy outcomes, including low birth weight and preterm delivery. This is a conditional recommendation. We suggest counseling that women with IBD with moderate to severe disease activity have an increased risk of spontaneous abortion. as compared to women without IBD or women with mild IBD. I think this is really important and goes back to the whole concept of the importance of controlling disease activity for conception and for pregnancy. We suggest counseling that pregnant women with IBD have an increased risk of venous thromboembolism during pregnancy as compared to pregnant women without IBD. And we suggest counseling that pregnant women with IBD have an increased risk of VTE during the postpartum as compared to pregnant women without IBD. I think these last two statements about VTE are very important. Certainly, if any of our IBD patients who are not pregnant are admitted to the hospital, they get started on low molecular weight heparin. That's a quality measure. But for our pregnant patients, should they be getting VTE prophylaxis in the peripartum time, and when they do deliver, particularly by C-section, should they be going home on VTE prophylaxis? And these are important discussions to have with the OB. In our centers, they certainly get compression stockings and other preventative measures, and many patients with C-sections and IBD will go home on VTE prophylaxis. Millie, is that the same at UNC?
It is to some extent. I think those with the highest risk, yes.
Yeah.
A low risk patient with no disease activity, incredibly controlled inflammatory bowel disease. We consider that somewhat differently, and they may not. So I think it's an individualized decision. But what is so important are these grade statements, that the awareness. So you need to have
Yeah.
the discussion and be able to talk about the scenario for the individual patient with OB and tailor their own plan for VTE prevention.
Absolutely. And the consensus statements: controlling disease activity during pregnancy among women with IBD is critical to reduce adverse outcomes. I think we keep saying the same thing over and over, but it is so important. And sometimes we'll have a patient come in who says, I don't want to start any therapy until I have my children. And that actually makes it harder for them to have children and harder for them to have healthy children or have uncomplicated pregnancies if they have active disease. In addition to talking about the risk of the medication, you need to talk about the risk of the disease.
So moving on to fetal and neonatal adverse events. Next slide. So our grade statements: we suggest counseling that children born to women with inflammatory bowel disease have an increased rate of neonatal ICU admissions and hospitalizations in the first year of life. We also suggest counseling that children born to women with active IBD have an increased rate of small for gestational age and low birth weight compared to children born to women with inactive IBD. And I think that's a huge statement to talk to our patients about in preconception counseling, that really, when you compare active to inactive, it really has really untoward, outcomes for the infant, for the fetus and the infant. So we really want to control that underlying IBD, and that can be helpful for them in understanding the importance of staying on therapy or initiating advanced therapy. The next one, we suggest counseling that children born to women treated with anti-TNF therapy, ustekinumab or vedolizumab during pregnancy, have no increased risk for early childhood malignancy. And again, these are conditional recommendations, but overall important to help our patients to understand the factors associated with decisions of continuing medical therapy. Our next statement: we suggest counseling that children born to women treated with anti-TNF, ustekinumab, or vedolizumab have no increased risk for early childhood developmental delay. And then finally, we suggest counseling that children born to women treated with thiopurines have no increased risk for early childhood developmental delay. So really, we have data following these children out that they're meeting all of their developmental milestones, and that these therapies during pregnancy do not impact those outcomes. Next slide.
Yeah. And then Millie, we just presented our data at DDW and or submitted about the data from Piano on over 400 patients over 4 years of age from the registry, and it supported all of this, which was really reassuring.
Incredibly so. So it supported the fact that not only early in the first year, but when you follow children out further, we're still seeing no adverse effects of biologic exposure during pregnancy or thiopurine exposure. So, in summary, let me do this slide and then I'll turn it over to Uma. When we look at pregnancy and neonatal adverse events, there is an increased risk of low birth weight with active maternal IBD. We see that increased risk of neonatal intensive care unit and increased risk of small for gestational age. And so, obviously, helping to avoid active IBD during pregnancy can improve outcomes. We also see an increased risk of preterm delivery, again, linked to active disease, increased risk of spontaneous abortion with active disease, and an increased risk of venous thromboembolism. So again, collecting these data together really speak to the story of controlling inflammation throughout the course of pregnancy. Next slide.
Okay, so our very last section is vaccines, and there actually have been some important updates here. So the grade statement, we recommend that inactive vaccines be provided to children born to mothers with IBD on anti-TNF agents. It's a strong recommendation. A new change is that we suggest that live rotavirus vaccine may be provided in children with in utero exposure to biologics, and we'll show you the data for that. And then we recommend that live BCG vaccine be avoided in the first 6 months of life in children with in utero exposure to anti-TNF factor therapy due to risk of disseminated TB and associated mortality. After 6 months, it's fine to give the BCG. This was a strong recommendation, but there's an asterisk here that regional risk should be considered. So in countries with very high risk of tuberculosis, here is an exception where they may want to hold the TNF early in the mother if they want to give the BCG vaccine. And I think our colleagues in Colombia talked about that. Or you can also measure drug levels early at 2 or 3 months. And if the drug levels are less than 2 micrograms per ml, they may go ahead and give the BCG vaccine at that point in areas where TB is endemic and is the leading infectious disease mortality risk for children. Inactive vaccines should be given on schedule these are consensus statements, on schedule to infants of women with IBD, regardless of in utero IBD medication exposure. So when it comes to inactive vaccines, regardless of medicine, you're on schedule. Children exposed to JAK inhibitors or S1P modulators in utero may receive live vaccines after 1 month of age. These agents have very short half-lives and should definitely be out of the infant system by 1 month. And then in direct contraindication to the EMA statement, we felt that live vaccines can be given to infants of mothers breastfeeding while on biologics. And the reason for this, as Millie discussed, is the amount that transfers in breast milk is really minuscule, and that is not an indication to avoid live vaccine. So what is the data supporting our change with respect to live rotavirus vaccine? So there is retrospective data on infants who have received rotavirus vaccine with no serious adverse events. But the big change was the prospective study from the Canadian Immunization Research Network, where they took offspring of mothers on biologics for various reasons and ended up giving rotavirus vaccine to 168 of these children with no serious adverse reactions. And Cynthia Sau's group presented the IBD data from that cohort, where it was 50 infants who received rotavirus vaccine with no adverse events at 7 days, 1 month, and 9 months after vaccination. So, Millie, do you want to do the first summary?
Sure. I'll wrap up first with key points and then turn it over to you. And then I've got some questions in the Q&A. And please do continue to put your questions in the Q&A. We reserve some time at the end of the webinar for that. But key points: reduced fertility with active disease and IPAA. And so this is your counseling points for our patients. Controlling active disease will actually help to improve their fertility. No risk of flare with oocyte retrieval. That we do see an increased risk of preterm delivery. And in many of the cohorts, that's actually linked to active inflammation, as is the risk of spontaneous abortion. We see that increased risk of VTE. Again, key points of awareness and counseling to help to improve outcomes for our patients. From a clinical guidance perspective, really continue all biologics and thiopurines throughout pregnancy and lactation. Avoid those small molecules, not the thiopurines, but the S1P receptor modulators, the methotrexate, and the JAK inhibitors with pregnancy and lactation. That preconception counseling improves outcomes, and that preconception counseling can be performed by us, the gastroenterologist, and certainly with collaboration with MFM and others. That providing low dose aspirin can help to reduce preterm preeclampsia, which our patients with inflammatory bowel disease have increased risks for, and that we know that that low dose aspirin is not associated with an increased risk of flare. And that performing a C-section for delivery if they have active perianal fistula or rectovaginal fistula, and consider this amongst women with an IPAA and directly counsel surrounding what the outcomes could be with a complicated vaginal delivery. So with that, Uma, you're next.
Yeah, so the key points for the baby, there's an increased risk of IBD if a first degree relative has IBD. So increased risk for the baby. There's an increased risk of low birth weight with active maternal disease, increased risk of NICU stay, increased risk of small for gestational age with active maternal IBD, but there's no increased risk of infant infections, malignancy, or developmental delay with biologic exposure. So the clinical guidance is that inactive vaccines should be given on schedule regardless of medication exposure, and that live vaccines should be given on schedule except BCG, which can be given after 6 months, in infants exposed to biologics in utero. So for rotavirus, you can give it within the first 6 months. BCG should be avoided till after 6 months. Oral polio was not really given in any of the regions represented, but if you are giving oral polio vaccine in your region, that should probably wait till after 6 months as well. So with that, we are happy to take questions. If you live in the United States and have a pregnant patient with inflammatory bowel disease or are pregnant with IBD yourself and would like to enroll in the Piano Registry, you can do that on our website. The slide deck you saw today is now available on this website in both English and Spanish. We also have excellent patient videos in 7 languages that summarizes this slide deck into patient-friendly language. And also keep an eye out for the AIBD network videos from our 10 leads from the global consensus for the 10 subjects that you saw, breaking it down even further. So thank you. I'll leave this slide up and we'll take some questions.
Great. Well, so Uma, let me, there are a number, and we'll try to get through as many as we can, over the time allotted. The first question had to do with our recommendation for low dose aspirin. And given that the ASPRI study looked at 150 milligrams, and clearly we have 81 milligrams, or we have 2 of those at 162, what are you doing in your practice? Which are you recommending?
So it's really interesting because I feel like all the OBs and MFMs went to a meeting where they suddenly switched from 81 to 162 at our center. And so we try to get close to the ASPRI study of 150. And the reason they have 150 is their aspirin comes as 300 and they cut it in half. And that's why they use 150. So we tend to use 162 now.
We do as well, although last year I was using 81. So I think that in general, they could also collaborate with OB as to which they would choose, but we should get them on close to the evidence-based dose of 150. We also, I knew this question would come up, and we could both comment on it, Uma, but the question was surrounding a young woman who really needs a JAK. And how do you deal with that? A patient who needs a JAK inhibitor, but really also wants to become pregnant.
So, it's really a challenge. So the first thing we say is, do you have any other medical options? So I do have some Crohn's patients who went on a JAK and then the IL-23s came out. And so if they've never been on an IL-23, I will try to switch them to an IL-23 and see. But if you have a patient who did not respond to TNF, did not respond to Veto, did not respond to an IL-23, this is the only thing that is keeping them going, we have a conversation and we say, if you have ulcerative colitis, are you willing to risk a colectomy if you come off drug? Or are you willing to use a surrogate to have your family? And if the answer to both of that is no, we talk about the risks of JAKs, the reprotox data showing for upadacitinib that in animal data, the birth defects were seen at doses used in humans. The limited human data that we have, which so far does not show an increase in birth defects. And then we continue. And I think in Piano, we have about 20 patients enrolled between UPA and TOFA. How about you?
No, that's exactly what I do too, is if I have another option, I'll do it. It's typically the IL-23 based on the timing of when the drugs came out. I do feel more comfortable with the JAK inhibitors in the second and third trimester,
Hmm.
and so if I can even get them through first trimester and then potentially restart the JAK inhibitor, I feel a little bit better about that just based on organogenesis. But in reality, I have the same conversation you do, and some of my patients choose to stay on the JAK inhibitor because it's their only option. And again, the human data thus far are reassuring. It's just that it's very slight and small. And so, we have to take these decisions individually, and patients do need to be aware of the animal data that do show some of the tox issues you described. So I think that certainly it's an important endeavor where education is important and going over individualized options.
Hmm.
One question that to follow up too, if you had a mom who was stable on a jack and really wanted to breastfeed, the question is, how long should they be, if they did decide to change to another therapy, how long should they be off before breastfeeding? And I don't think we have a specific answer, but generally I would say 1 to 2 weeks. In that scenario, the half-life is really quite short.
The half-life is really short. I would have to go back and look at the papers that Mete and Dana published because I think it does stay in the breast milk longer than the dose.
Mhm.
That's the thing. There is some storage, and so I think 1 to 2 weeks is reasonable. But if they, I've had patients really want to breastfeed despite being on a jack, and it is technically under the relative infant dose of 10% at 3%.
Right.
So are we being overly cautious here? I just feel like breastfeeding is a little bit more elective than the pregnancy itself and have
Mhm.
more caution in that setting.
No, absolutely. One of our participants asked about data on combination therapy, infliximab plus thiopurine, and we certainly have that from Piano, and that is still recommended to continue both during the course
Yes,
of
if
pregnancy.
appropriate for the patient, continue both. What about combo with different biologics? What do you do
Right.
there?
Well, and certainly we have data in Piano surrounding when individuals who switch from one to another during
Yeah.
pregnancy. And it's not a lot, but we didn't see adverse outcomes associated with that. And in theory, they could have been on dual. I can't imagine that dual biologics, necessarily would cause an issue. If you need to change your patient's biologic and control active inflammation, I would change your patient's biologic to
Yeah.
control active inflammation. Another question, rotavirus vaccine. We talked about that if the patient is on biologics, we could still give. This is interesting. What about the patient who is on a thiopurine? Any hesitancy there?
No, I think with the small molecules, it should be out of the system in a month, for any of them, for JAKs,
Mhm.
S1Ps, thiopurine. So we never limited rotavirus vaccine for thiopurines.
No, great. So another question surrounding the avoidance of BCG vaccine, and the fact the question really is surrounding is that independent of what they're on, and I think we probably don't have enough data about IL-23s and
Yeah.
anti-integrins that's pretty specific to TNFs. Is that correct?
It is specific to TNFs, and you can always check a drug level because maybe the Veto, the IL-23s will be out of the system earlier than 6 months. And even for a TNF, if you check the infant's drug levels and they're low, I would say less than 2 micrograms per ml, then you can give it. And so if you have any concern and want to give it, you would just check a level. For vedolizumab, technically, there is no limitation about giving live vaccine. So if the mother was on vedolizumab, then there should be no harm in any live vaccines because it's allowed for the mother.
Mhm. Right, exactly. So kind of medication specific, but the
Right.
6 months is really the TNF. And the
TNFs.
reason that was a strong recommendation is unfortunately there was a very bad outcome of disseminated TB
Yeah.
where the infant died, associated with BCG vaccine. So whenever there is such a compelling adverse event, you practice caution from that
Yeah.
standpoint. Let's see. And so, really, with that, actually, one of our patient participants asked about donating the placenta based on the placenta data you have. And I know at UCSF, you all are doing that and collecting placentas. But at this point, I don't believe it's at other sites.
Yeah, the problem is the placenta deconstructs the minute it comes out of the mother. And so it has to be collected and processed within 30 to 60 minutes. So we actually have this lovely man named Matthew who 365 days a year goes and collects placenta from UCSF Hospital. And so that is the issue. We would love to collect it from all the different hospitals. That would make the study much faster, but you have to have a 24/7 placenta team on call to retain that. And we're hopefully going to bring UNC on board so we can collect your
Yes, try to
placentas.
get a few more in there.
Yeah.
And questions about dad. Any data on Jack exposure to the father preconception? There's a little bit of data from the clinical trials for
Yes.
upadacitinib and tofacitinib.
Yes, and then they also did the MANTA study for filgotinib, which was mandated by the FDA, and it showed no harm to sperm from exposure to filgotinib, and none of the other JAKs had any signal to warrant a study. So it looks like, from what data we have available, that it's not an issue.
And another question, one of our consensus statements from the beginning, really in collaboration with MFM, was that we really should be discussing kind of a nutritional assessment, in preconception. In your practice, which vitamins or minerals do you check? Is that just a standard check, B12, D, kind of some of those, or is there anything
Yeah, we do
specific?
B12, iron, vitamin D.
Mhm.
Those are the three, and sometimes zinc, depending on the
Mhm.
patient. And then we do have an IBD nutritionist, and OB has a OB nutritionist that the patient will often see
Mhm.
if there's any question of malnutrition. So our short bowel patients, our patients
Mhm.
who are recently ill. But I would say our healthy moms with normal labs, B12, folate, vitamin D,
Mhm.
iron.
No, I agree. And that's what we do in our practice as well. Great. So with that, I think we have answered the questions. One shout out that our colleague Mete is doing a study that is patients with JAK inhibitor exposure in pregnancy. And so for our European participants, please reach out if they have any patients with JAK exposure because they're doing their global echo study that is still enrolling.
Yes.
Otherwise, we would encourage all of our participants to visit the Piano website, download slides, and help to spread the word.
Great. Thank you. Yes, the goal of this is to get this out to women in all parts of the world so that they can be informed and their providers can be informed and everybody gets the same standard of care, which would be excellent. So thank you, Millie. Thank you to all the Global Consensus participants. And if you need to hear this again, it's going to be posted on our website shortly. Thanks, everybody.
Thanks, everybody.